Hello dear nursing students, a very pleasant good evening. I am Priyadarshini back here with another important probable MCQ discussion series for your obstetrical and gynecological nursing and community health nursing. I hope everyone is there. Yes, we will wait for 5 minutes. Yes. And what about your preparation for your MSc entrance examination? Since the registration process has been started and many of you has happily engaged in the registration process, how things are going, how is your preparation is going? Good evening Ashush. Yes, tell me, how is your preparation journey going? Is it as productive? You are studying the concepts as per the track of plan MSc 5.0, or is there is any delay in the preparation journey? Nothing like that? Yes. So let's go into the session. So next we will discuss the important MCQs of obstetrics and gynecology and community health nursing in this session. So the first MCQ which we are going to discuss is from OBG, and this question, while preparing for this question, I was literally feeling so important. Like, I am seeing the question papers of 2018, 19, 20, 21, 22, 23 and 24. There is one question from this particular topic. That is the common signs in the pregnancy. Right. So that's why I have put this question. So let's get into the question. So which of the following is considered the earliest clinical sign? The earliest clinical sign of pregnancy and can typically be detected by 6 weeks of gestation. So, as I said you, this is very important question and many people have started to answer correctly also. Right. So, this is one of the most important question, where what is the first and earliest clinical sign which is seen in pregnancy, that too in 6 weeks. So, these two are the key points. First is the earliest sign, earliest clinical sign of the pregnancy, and followed by which is detected in the 6 weeks of gestation. Obviously, the correct answer is B. Yes, many people are answering B and some people are also answering C. No, C is not the correct answer. B is the correct answer. The correct answer is Goodell sign. What is meant by Goodell sign? Goodell sign is the softening of the cervix. Goodell sign is the softening of the cervix. Softening of the cervix. This particular sign is visible at the 6th week of pregnancy, and it is considered to be the earliest sign of pregnancy. Whenever you see the keyword of earliest sign of pregnancy, you have to close your eyes and you have to go and take Goodell sign. And another one key term is, what is the softening of the cervix? What is the term softening of the cervix? Like when they ask the MCQ, like what is softening of the cervix during the pregnancy is termed as, that is Goodell sign. Next is Chadwick sign. What is meant by Chadwick sign? Chadwick sign is the bluish discoloration. Okay, is the bluish discoloration of your cervix, vulva and vagina. So why this particular sign is happening? Why Chadwick sign is happening? What is meant by Chadwick signs? Please answer in the chat box. Like, Chadwick sign is the bluish discoloration of your cervix, vagina and vulva. So why this bluish discoloration is happening? This bluish discoloration is happening because of the increased venous flow. Okay, because of the increased venous flow, this bluish discoloration is happening at the time of the pregnancy. And this sign happens at what weeks? Any kindly answer me. This sign happens in which week of your pregnancy? This sign happens in the 8th week of your pregnancy. Happens in the 8th week of your pregnancy. Next we have the Hagar sign. What is meant by Hagar sign? Hagar sign is termed as the softening of the isthmus. Softening of the isthmus. Softening of the isthmus is termed as your Hagar sign. Where is your isthmus present? This is your uterus. This is your internal. This is your cervix, your internal os, and this region is termed as your isthmus. Right? This is your isthmus. And why this Hagar sign? Like why, what is the principle behind this Hagar sign is, it is already understood generally the blastocyst is going to be implanted in the upper part of the urine. Upper part of the uterus. The blastocyst is going to be implanted in the upper part of the uterus. So what happens on bimanual examination? On bimanual examination, while we are doing bimanual examination on palpation, since the lower segment of the uterus, the isthmus part is soft, you can able to do the bimanual palpation where their two fingers will be coordinating. So it will be better understandable with the picture. So this is Hagar sign. This is Hagar sign. On bimanual palpation where the uterine isthmus is being very soft because of the implantation of the blastocyst on the upper segment of the uterine cavity. So what is happening? You can able to feel the coinciding of the fingers on bimanual palpation. That's why this is termed as your, this sign is termed as your Hagar sign. So last sign which we had is Piscatus sign. What is meant by Piscatus sign? Piscatus sign is the unequal growth of the uterus. So anyway, in the uterus, at one part of your uterine cavity, the blastocyst is going to be implanted. Right. So this in turn causes the uneven elevation or uneven growth of the uterus. So this sign is called Piscatus sign. And we also have another important signs that we are going to discuss is, like already we have discussed Goodell sign. Goodell sign is what? Softening of the cervix. We have discussed it. It is seen in the 8th week, and the most important key point, it is the first sign. Next is Chadwick sign. What is Chadwick signs? We have discussed it is bluish discoloration of the cervix or vagina on the vulva because of the excessive venous flow to that particular region, right? So this is always seen in the 8th week of pregnancy. Next is Osiander sign. So these are the common signs which are actually asked in your examination. What is Osiander sign? It is the lateral vaginal wall pulsation. This pulsation is because of the uterine artery, since at the time of pregnancy there will be increased amount of blood supply to the uterus, which in turn leads to the pulsation of the uterine artery, which then arises this Osiander sign. This sign is also seen in the 8th week of the pregnancy. Next we have Palma sign. What is Palma sign? Rhythmic uterine contraction. Better word is rhythmic uterine contraction or painless rhythmic uterine contraction is termed as your Palma sign. Okay, painless rhythmic uterine contraction is termed as your Palma sign. So next we have Hagar sign, which we have, Piscatus sign, which we have already discussed. That is your unequal growth of the uterus because of the implantation of the blastocyst in the one side of the uterus, which in turn gives an unequal presentation or growth presentation. Next is your Hagar sign. Hagar sign is the softening of the isthmus where it arises on bimanual palpation. You can see the coinciding of the fingers, right? Shall we go to the next MCQ? Yes. This is Hagar sign. What is the sign? This is Chadwick sign. This is Chadwick sign. Chadwick's sign. So what is Chadwick sign? That is the bluish discoloration of the vagina and vulva and the cervix. Yes. So next question. A 24 years old primigravida gravida presents for a routine antenatal checkup. The 24 years old primigravida, okay, first time the mother is pregnant and present for the routine antenatal checkup. On abdominal examination, the uterine fundus is palpated at the level of umbilicus. So here they are going to ask you, like at the level of umbilicus, what is the gestational age? What is the gestational age? Is MCQ. So which of the following is most likely the gestational age when it is on the umbilicus and when it is at the umbilicus? So any answers? Many people are answering B. Is B is the correct answer? So there is an easy step in evaluating the weeks of gestation in the uterine, like in the fundal examination. Just remember this diagram. You can also draw along with me. You can also draw along with me. So consider this is your symphysis pubis. This is your symphysis pubis. This is your symphysis pubis. And this is your umbilicus. This is your umbilicus. This is your umbilicus. And this is your xiphisternum. Xiphisternum. This is your xiphisternum. So first you have to make sure, remember this picture, consider this is your symphysis pubis, this is your umbilicus, and this is your xiphisternum. So now the midway, now we are going to draw another we are going to divide them into partitions. So first is the midway between your umbilicus and symphysis pubis. Midway between your umbilicus and symphysis pubis you are dividing. Next is, this is the lower border of the umbilicus. This is the lower border of the umbilicus. Lower border of the umbilicus. This is the lower border of the umbilicus. And this is the upper border of the umbilicus. Upper border of the umbilicus. Next, again, from this umbilicus to xiphisternum, we are dividing them into like 1/3 between your umbilicus and xiphisternum. And again, we are dividing into another part, that is your 2/3 between your umbilicus and xiphisternum. Right? So just you have to remember this diagram. This is how you have to categorize it, like xiphisternum, the umbilicus, your symphysis pubis, your umbilicus, and your xiphisternum. Right? So what you are doing is, first you are drawing a central line between your symphysis pubis and the umbilicus. That is termed as your midway between your umbilicus and symphysis pubis. Next, we are going to the umbilical region. In there, first you are drawing the lower border of the umbilicus and you are drawing the upper border of the umbilicus. In between the umbilicus is there. Next, between the umbilicus and the xiphisternum, you are dividing them into two parts again. That is the 1/3 between your umbilicus and xiphisternum. Next is the 2/3 between the umbilicus and xiphisternum. So now tell me, uterus will be at the level of xiphisternum at which weeks? Just tell me, uterus will be at the level of xiphisternum at which weeks? Uterus will be at the level of xiphisternum at which weeks? Tell me. Soon. Attentive students can tell me. Like, uterus will be at the level of xiphisternum at the which week of pregnancy? Tell me. Yes. It is your 12 weeks of pregnancy. That's just, you have to remember this. Uterus will be at the level of xiphisternum at 12 weeks of pregnancy. At 12 weeks of pregnancy. So just now you have to add 4 at each level. Now you are going to get these correct answer. Yes, Ashish, 12 weeks is the correct answer. Right. Now you are going to add 4 again. So what you are going to do? So 12 plus 4 again, 13, 14, 15 and 16. This is 16 weeks. And you are going to add another 4. So 16, 17, 18, 19, 20. This is 20 weeks. Next, at the level of your upper border, you are going to calculate. So 20, 21, 22, 23, 24 weeks. 24 weeks at the upper border of your umbilicus. Next, 24 plus another 4. What is 24 plus another 4? That is 28 weeks. That is 28 weeks. Then, here, 28 plus another 4, 29, 30, 31, 32 weeks. So it is 32 weeks. Next, 32 plus another 4, that is 36 weeks. So it is very easy now. It is very easy, children. Okay. Sorry. So I asked, uterus will reach at the level of symphysis pubis at which week? It is 12 weeks. Okay. It is 12 weeks. Right. So now we are going to learn like how we are categorizing it. So we have categorized into three parts first: symphysis pubis, umbilicus, and the xiphisternum, right? Symphysis pubis, umbilicus, and the xiphisternum. Then we divided the symphysis pubis and the umbilicus into two parts, that is the midway between your umbilicus and symphysis pubis. And at the level of umbilicus we have divided into two, that is like upper border of the umbilicus and the lower border of the umbilicus we have divided. Then from the umbilicus to the xiphisternum we have been dividing it into 1/3 between the umbilicus and the xiphisternum and 2/3 between the umbilicus and xiphisternum. Yes, at the level of symphysis pubis it is obviously, at the level of symphysis pubis it is obviously, at the level of symphysis pubis it is obviously 12 weeks. So from that you have to remember only that value. From that you have to add 4 each, like at the midway between your umbilicus and your symphysis pubis you are going to have 16 weeks. So at the lower border of the umbilicus it is 20 weeks. When you palpate the uterus at the lower border of the umbilicus it is 20 weeks. When you palpate at the upper border of the umbilicus it is 24 weeks. When you palpate in the 1/3 between your umbilicus and xiphisternum it is 28 weeks. When you palpate at 2/3 between your umbilicus and xiphisternum it is going to be 32 weeks. And when you palpate at the xiphisternum it's going to be 36 weeks. So now coming back to the question, so when we come back to the question, we are asked at the level of umbilicus. So at the level of umbilicus it is like from 20 to 24 and it is 22 weeks. It is 22 weeks is the correct answer. Am I right, children? So 22 weeks is the correct answer, which means at the midway between your upper border and the lower border it is 22 weeks of pregnancy. Okay, 22 weeks of the gestational age is 22 weeks. And here we also have, like at the 40 weeks of gestation, what is the case? At 40 weeks of gestation, where we are expecting the uterus to be. So at 40 weeks of gestation, what will happen? At 40 weeks, the head of the baby will start to sink, will start to descend inside the pelvis. The head of the baby will start to descend inside the pelvis. So what happened? It will again come back to the level of, 32 weeks. It will come back to the level of 32 weeks. So at 40 weeks, since the head is descending, what will happen? The uterus will be, the period of gestational age will be at the level of 40 weeks. Sorry, at the level of So at the level of 40 weeks, okay, at 40 weeks what is happening? The uterine, the head of the fetus will start to descend downwards. So at that level what will happen? The uterus will start to go downside, so that what will happen? You can able to palpate the period of gestation at the level of 32 weeks. So that is the case here. So that symptom, like when the head is started to descend downwards, where the mother gets a relief from the respiratory distress and other symptoms, is termed as what case? It is lightening. Right? It is lightening. So it is like, otherwise you can tell at the level of 32 weeks, or you can tell at the level of 2/3 between your umbilicus and xiphisternum at 40 weeks. This is the case. Right? So how will you differentiate whether it is, when the mother is not knowing the LMP, how will you differentiate in this case? In this case, what you have to do, you have to check for the ballardment. When you feel the ballardment, it is 32 weeks. When you doesn't feel the ballardment, since the head is descended, it is 40 weeks. This is how you have to come to the conclusion. There might be tricky questions in these cases, so this is how you have to come to the conclusion. So let me repeat once again. First is, remember the symphysis pubis, the umbilicus and the xiphisternum. Then we are drawing a middle line, that is midway between your umbilicus and symphysis pubis, and followed by the umbilicus you are dividing into two, that is your upper border of the umbilicus and lower border of the umbilicus. Then from the umbilicus to the xiphisternum you are dividing it into two parts, that is your 1/3 between your umbilicus and symphysis pubis and 2/3 between your umbilicus and symphysis pubis. So based upon it, as we all know, the uterus will be felt at the symphysis pubis at 12 weeks of pregnancy. So 12 weeks you have to add 4, 4, 4 and 4, and so that you will get the overall component. So coming back to the question, so when you will see the uterus, when the uterus will be palpated at the level of umbilicus, obviously upper border is 24 weeks and lower border is 22 weeks. The midway, that is 22 weeks, will be seen at the level of umbilicus. So this is the correct answer. Is that is clear, dear children? Yes, that's it. So the correct answer is 22 weeks. Don't confuse yourself, just remember this diagram, or you can draw the diagram. So since I repeated many times, so you can draw the diagram and you can remember it so easily. So whenever you want to work up, you just work up, just do a small workup and you can come up with the conclusion of the answer. So next we will go to the next question. So this is an additional table, an informative table which I have added for you. At 12 weeks, you can see the uterus is palpated at the pubic symphysis. At 12 weeks, the uterus is palpated at the level of your pubic symphysis. So at 22 weeks, it is at the level of umbilicus, where we know that the upper border and lower border levels. Right. Next is immediately after the delivery, just below the umbilicus, it comes to the 12 week size. So immediately after the delivery, the uterus will descend at the level to the umbilicus, that is at the level of 20 weeks. Next, day 1 post delivery, there will be no changes in the height. Day 1 of the post delivery, there will be no changes in the height of the uterus, and day 2 onwards decrease by 1 finger breadth per day below the umbilicus. From day 2, day 1 there will be no changes. Please remember this. This is also repeated questions in your MSc entrance examination. For your paper 2023 and 2021, this question is repeated. Okay. If we have more option 24 weeks, then what is the right answer, ma'am? If we have more option, see, obviously it is understood that they are directly asking the question like at the level of umbilicus. Okay, at the level of umbilicus, and it is very clear that the lower border is 20 weeks and the upper border is 24 weeks. Okay, lower border is 20 weeks and upper border is 24 weeks. Since the umbilicus is in the midway between the upper border and lower border, so it is obviously understood that at the level of umbilicus it will be 22 weeks only. Please don't confuse yourself. Right. So next we are coming back to this image. So this is very important point as I said you. So day 1 on post delivery, there will be no changes in the uterine height, uterus height, or then when from day 2 onwards, there will be 1 finger breadth per day below the umbilicus. 1 finger breadth, it will be reducing below the umbilicus. So that you have to remember. Right? Next. The next question, at 26 years old, Primi Gravida at her routine antenatal visit reports that she has not yet felt any fetal movements. So, just remember 26 years old, Primi mother. Keywords in obstetrics and gynecology is very important. You have to analyze either she's a Primi Gravida, she's a multigravida, or she's an early gravida. These word speaks volumes in these MCQs as a key point. So right, just remember 26 years old, Primi Gravida mother at her routine antenatal visit reports she has not felt any fetal movements. Immediately then you will get panic. First you have to read the question completely. Right, her gestational age by last menstrual period is 17 weeks. So she's a Primi Gravida mother. She's a Primi Gravida mother and she is not feeling any kind of fetal movements and her gestational age is 17 weeks. Right. So what is the most appropriate response by the nurse? As the question implies, you can able to analyze what is the term to be remembered. What is the term you will tell for the mother who feels her first fetal movement? The first fetal movement felt by the mother. What is the terminology? The first fetal moment. Fetal moment felt by the mother. What is the terminology is termed as? That is termed as quickening. That is termed as quickening is the term for the primigravida or the multigravida who feels the movement of the fetus for the first time. Movement of the fetus for the first time. So what is the ideal timing of this? What is the ideal timing for this quickening? What is the ideal timing of this quickening? The ideal time of quickening is 18 to 20 weeks. This is also very important to note. It is 18 to 20 weeks in case of primi. In case of primi, and it is a common sense that you have to know. In case of multi, it will be 2 weeks earlier. In case of multi, this quickening process will be 2 weeks earlier. That is 16 to 18 weeks. The the multigravida can feel the quickening. Okay, the multigravida can able to feel the quickening. Just understand. At 18 weeks, the primigravida will feel the quickening moment at 18 to 20 weeks. The primigravida. Whereas in multigravida, it is a common sense that when comparing to the primigravida, the multigravida can able to she can able to easily grasp the fetal movements so earlier. So it is just a week, 2 weeks difference. It is just 2 weeks difference. It is for multigravida. It is 16 to 18 weeks. It is to 16 to 18 weeks. Very good, Ashish. It is 16 to 18 weeks. Right. So now coming back to the question, what is the most appropriate response? As the question implies, the mother is a primigravida and she is in just 17 weeks and she is not feeling any fetal movements, and she is informing this to you. So what will be your nursing response? Just see the first option. Reassure her that this is the normal and the fetal movements are typically felt at 18 to 20 weeks. Yes, this is the very correct option. This is what you have to tell. Let's approach the another options also. Like immediately refer for the ultrasound to check the fetal viability. No, this is the wrong option. So since at 17 weeks she's a primigravida mother, at 17 weeks she will not feel any kind of fetal movements. Right. So since she is a primigravida. Next, inform her that her fetal movements should have been felt by 14 weeks. It is scientifically wrong point. The primigravida, it should be felt at 18 to 20 weeks. Next, explain that the fetal movements in primigravida are typically felt after 22 weeks. So this is also scientifically wrong answer. So the correct answer is reassuring the mother that it is a normal finding and normally you will feel the first fetal movement. That is scientifically termed as quickening at the 18 to 20 weeks. Right? We will go to next question. Yes. So to be very clear, primigravida 18 to 20 weeks is the correct answer. In case of multigravida, just remember 2 weeks difference. Just remember 2 weeks difference. 2 week difference from multigravida to primigravida. So 16 to 18 weeks, the mother can able to feel quickening in case of a multigravida mother. Right? Next. So the next question. Which of the following ultrasound scan is mandatorily performed in all pregnant females between 18 to 22 weeks to assess the fetal structural abnormalities? So here they have given which scan you are going to take, and at 18 to 22 weeks specifically they are asking, and it is used to assess the fetal structural abnormalities. It is used to assess the fetal structural abnormalities. Now tell me what is the answer. Yes, very good. Afroz Alam, Swarnalini Shi, Saraswati Raut. Very good response. The correct answer is anomaly scan, or otherwise known as TIFA scan. What is meant by TIFA? What is the expansion of TIFA? Anyone can comment me what is the expansion of TIFA? TIFA is the targeted imaging of fetal anomaly. So this TIFA scan is usually done at 18 to 20 weeks, but this scan can be done till 22 weeks. So this is why we are choosing C as the correct answer, and specifically anomaly scan is the only scan. This is your targeted imaging of your fetal anomaly scan is the only scan which can able to find out the structural abnormalities system wise, starting from your CNS, your cardiac, your limb abnormalities, everything can be analyzed with this anomaly scan, and this scan is one of the most important scan which has to be definitely done. Okay, this scan should not be skipped, and it has to be definitely done at the 18 to 20 weeks, and it can be also done till 22 weeks. That is the key term you have to note. You will be knowing it should be done at 18 to 20 weeks, but it should be done it can be done till 22 weeks. So that is then another important point which you have to note. Right? Very good, Ashish. Right? So next we will learn about other scans in detail. So first is dating and viability scan. These are the antenatal USG scans which are taken. First is dating and viability scan. This dating and viability scan is done in 6 to 8 weeks of your pregnancy, which confirms the pregnancy and cardiac activity. This dating and viability scan where the mother will be confirmed that she is pregnant and the pregnancy is intrauterine. Like it should not be ectopic. It should not be the blastocyst, the particular pregnancy happening should not be implanted in other parts other than the uterine cavity. So this will be confirmed by your dating scan, which is done at 6 to 8 weeks of your pregnancy to confirm the implantation is in the uterus, as well as to identify the cardiac activity of the uterus. Okay, cardiac activity of the fetus. Next is knuckle translucency test. This knuckle translucency test weeks are also asked in your examination, so it is very important to note when is the knuckle translucency test is done. Knuckle translucency test is done at 11 to 13 weeks of your pregnancy. 11 to 13 weeks of your pregnancy, additionally plus 6 days. 11 to 13 weeks of your pregnancy, additionally 6 days. Next, this is specifically done to screen the chromosomal anomalies, especially your Down syndrome. Your Down syndrome will be analyzed with your knuckle translucency testing. Okay, and chromosomal abnormalities. Right? So next is anomaly scan, as we discussed earlier, to fast scan, that to level 2 scan, which is done in 18 to 20 weeks, up to 22 weeks it can be done. Reinforcing the point, please remember, since people are preparing for competitive examination, it detects the fetal structural abnormalities and it is a mandatory scan. It should be definitely done. The scan which should not be skipped if there is a question, then you have to go and take this to fast scan only. Right? Next is your growth scan. Growth scan is done in 32 to 34 weeks to assess the fetal weight and growth and development. We are doing this growth scan. Next is placental localization via USG, which is done in 32 weeks and repeated at 36 weeks. Here where we are going to find out any kind of placental abnormalities, where the placenta is implanted, and if there is any placental abnormalities, we can able to find with this placental localization USG. At last, we have the fetal echocardiography. This fetal echocardiography is done at 20 to 24 weeks. Please remember, it is 20 to 24 weeks. Okay, 20 to 24 weeks. And it is only if CHD is suspected. If the patient is suspected with any congenital heart defects, so we are going for, if the mother is having the history of CHD child, okay, previous history of CHD for her child or family history, then we are going to go with this fetal echocardiography, right? Next, we will go to the next question. So, which of the following congenital anomaly is typically the first to be detected on ultrasound and can be diagnosed as early as 10 weeks? So, identify the ultrasonic findings which is done in the early pregnancy. Identify the ultrasonic findings which can be identified in the early pregnancy. So which is the condition that do at the 10 weeks of pregnancy? Which is the condition? You just answer me now. Just tell me which of the following congenital anomaly is typically the first to be detected on ultrasound and can be diagnosed as early as 10 weeks of gestation. like within 10 weeks of gestation, this anomaly can be identified. Very good, it is anencephaly. Anencephaly is one of the earliest identified congenital anomaly. What does mean by anencephaly? Anencephaly is the condition where, okay, your neural pore, okay, your failure of the closure of your anterior neuropore is there. Okay, the failure of closure of anterior neuropore failure of the closure of your anterior neuropore, which in turn going to cause the absence of cranial vault, and the brain is exposed. So this is the specific condition which can be identified earlier at the 10 weeks of gestation. Okay, and if there is a question, at what case it can be confirmed, like specifically it is best seen in which weeks. If there is a question when this anencephaly, at which week of gestation this anencephaly can be confirmed or betterly diagnosed, if there is a question, you have to go and take 14 weeks. The 14 weeks it is best seen. It is best seen in the scan at 14 weeks, right? So what is anencephaly? Anencephaly is a failure of the closure of your anterior neuropore, which in turn going to cause your cranial vault is absent, which in turn is going to cause the absence of your cranial vault, and this absence of cranial vault will lead to exposure of the brain tissue. This exposure of the brain tissue, how it is seen? So again, there is another important components inside this question, like they will be asking the signs, USG signs, what is specifically seen in this particular condition, and all other conditions we are going to see now. So here we can see frog eye sign, shower cap sign. In anencephaly, the USG signs you can see is frog eye sign, Mickey Mouse sign, What is the other sign? Frog eye sign, Mickey Mouse sign, and what is the other sign? That is your shower cap sign. So this will be better understandable with the images. So so now you can see absence of your cranial vault, which is leading to your presence of what? Absence of your cranial vault, which is going to lead to your exposure of your brain tissue. So this is termed as a whole Mickey Mouse sign, and this is termed as your frog eye sign, and this area is termed as your shower cap sign. Is that clear? So this is the findings of anencephaly, that is the USG findings of anencephaly. These are the specific signs used to determine these are the findings of anencephaly, right? So after the scan you can able to find the patient is having Mickey Mouse sign, frog eye sign, and the shower cap sign because of the absence of the cranial vault. Next we have the other conditions also. So in spina bifida, what is the important signs you have? In spina bifida, just tell me what are the important signs you have in spina bifida? Yes, answer me fast. In spina bifida, what are all the things you have? In spina bifida? In spina bifida, you will be having lemon sign. Okay, this is termed as your lemon sign. Okay, this lemon sign, and this is known as your banana sign. So these are the two signs which is seen in your spina bifida condition. Why this lemon sign and banana sign is seen? Lemon sign is because of the frontal bossing. Okay, this is because of the frontal bossing. And what is the reason for the, tell me what is the reason, or what is the reason for the banana sign? Banana sign is because of the downward displacement of the cerebrum. Banana sign is because of the downward displacement of the cerebrum. Downward displacement of cerebrum. Downward displacement of the cerebrum. Downward displacement of the cerebellum. Okay, it's cerebellum. Okay. So in spina bifida, what are the findings you will be seeing? In spina bifida, you will be seeing what? Lemon sign and banana sign. So lemon sign is because of the frontal bossing. This is the spinal cord anomaly. So this lemon sign is seen in case of frontal bossing. And what is that? In same spina bifida, we also have another sign that is termed as banana sign, which is because of the downward displacement of the cerebellum. Downward displacement of the cerebellum. So this is all about spina bifida. Next we have duodenal atresia. In duodenal atresia, D for duodenal atresia and D for double bubble sign. D for double bubble sign. Double bubble sign. Just remember D for duodenal atresia and D for double bubble sign. Just remember this. D for duodenal atresia and D for double bubble sign. Right. So next, what is the USG findings of posterior urethral valve? In posterior urethral valve, you have this keyhole sign. You have this keyhole sign. That is the USG findings of your posterior urethral valve. Since we have learnt about many signs, just we will have a recap. Okay, just we will have a recap. So in anencephaly, in the USG, what are the signs you will be seeing? That is your shower cap sign, frog eye sign and the Mickey Mouse sign. See, you can see the image. You can see the image. Okay, you can see the image clearly now. Okay. So this is the shower cap sign. This is the frog eye sign. And this is on overall is termed as your Mickey Mouse sign. Right? This is seen in case of anencephaly. And one more component you have to remember is, like, what is the best marker to decide anencephaly? What is the best marker? There is also a common MCQ, like what is the best biochemical marker? Do you people have the answer? Please answer me. What is the best biochemical marker? Marker to diagnose anencephaly. Best biochemical marker to diagnose anencephaly. What is the best biochemical marker to diagnose anencephaly? Tell me. It is acetylcholine esterase. It is acetylcholine esterase. That is the correct answer. This is also one of the common MCQ which is asked. This is also one of the common MCQ which is asked. Okay. This is also the common MCQ is asked. Sorry. Right. So this is also the common question which is usually asked. So next, anencephaly we have seen, which is the common biochemical, which is the best biochemical marker which is used in diagnosing your anencephaly is your acetylcholine esterase. And what are the signs you have seen in anencephaly? We have studied about shower cap sign, Mickey Mouse sign and your frog eye sign. Next we are going to talk about spina bifida. In spina bifida we have two important signs, which is including your banana sign and your lemon sign. So two kind of vegetables and fruits, right? You can remember in such a way, right? So spina bifida, just remember about the fruits. That is your banana and your lemon, right? So banana sign is because of the downward displacement of your cerebellum, whereas lemon sign is because of your frontal bossing in case of your spinal cord injury. Next, sorry, in case of your spinal cord anomaly. Next we have duodenal atresia. D for duodenal atresia and D for the sign which is seen in duodenal atresia is your double bubble sign. That is seen in your duodenal atresia. Next we have posterior urethral valve. In posterior urethral valve, the most important sign USG findings you have is your keyhole sign. Next we will go to the next MCQ. And next MCQ, right? A 19 weeks ultrasound, okay, a 19 weeks ultrasound of a fetus shows downward displacement of the cerebellum. Downward displacement of the cerebellum, as we already discussed, it is banana sign. And scalloping of the frontal bones. Scalloping of the frontal bones or frontal bossing, in any way you can tell, that is termed as your lemon sign, which we have already discussed. Which of the following condition is most likely the diagnosis? Obviously it is meningomyocele. And we have learned spina bifida, right? So spina bifida is bifurcated, okay? Spina bifida is bifurcated into meningocele, okay, meningocele and meningomyocele. Meningocele and meningomyocele. So what is meant by meningocele? Meningocele is the herniation of the meninges. Meningocele is the herniation of the meninges. Herniation of the meninges. There is your meningomyocele is herniation of your brain and spinal cord. Your meningomyocele is the herniation of your meninges and the spinal cord. That is herniation of both meninges and the spinal cord. Herniation of both meninges and spinal cord. Meninges and spinal cord. So as we already discussed, lemon sign and banana sign is always seen in case of your spina bifida. Spina bifida is other than bifurcated as your meningocele and meningomyocele. Meningocele is the herniation of the meninges, whereas meningomyocele is your herniation of both meninges and the spinal cord. Okay, so these two signs are definitely seen in your meningomyelocele, right? So now duodenal atresia, what is the thing? It is double bubble sign, as we discussed earlier, double bubble sign. And in anencephaly, you will see three signs: frog eye sign, Mickey Mouse sign, and your shower cap sign. In posterior urethral wall, which sign you will see in the USG? It is keyhole sign. It is keyhole sign. So is that is clear? We will go to the next question. So next, a 24 years old primigravida, at 10 weeks gestation, ask about her upcoming antenatal visit scheme. According to standard recommendations, what is the ideal number of antenatal visits? So here you have to note the ideal number of antenatal visits according to WHO it is different, according to your government of India it is different, right? So everything is there in the option. According to WHO, the ideal number of visit is different, and according to your government of India, the ideal number of antenatal visits is different, right? So according to the WHO, what is the ideal number of antenatal visits? Just put me in the comment box. According to WHO, what is the ideal number of antenatal visits? It is 8. According to WHO, the ideal number of antenatal visits is 8. And what is the ideal number of antenatal visits according to Government of India? According to Government of India, the ideal number of antenatal visit is 4. right? But normally they are specifically asking about what is the ideal number of visit. They are not mentioning it is from WHO or it is from Government of India. So normally the ideal number of antenatal visits should be 11 to 15 visits is the ideal recommendation, which is the correct answer. Since they are not asking about WHO or specifically about your Government of India, but the normal ideal antenatal visits that has to be happened for a pregnant woman is 11 to 15 visits. Okay, it is 11 to 15 visits is the correct answer. And you also have to remember this also. The ideal number of visits in as per WHO. Okay, the ideal number of the ideal number of visits as per WHO is 8. Okay. The ideal number of visits as per WHO is 8 and the ideal number of visits as per Government of India is 4. That also you have to keep it in your mind. Definitely you have to keep it in your mind. But what is generally, if they are asking what is the ideal, what is the how many amount of visits the mother should definitely have when they ask a question, you have to go and click definitely 11 to 15 visits is the ideal recommendation. Okay, so 6 visits per standard global consensus, no, this is scientifically incorrect. 4 visits as per WHO, no, WHO recommends 8 visits. 8 visits as per Government of India, no, Government of India recommends at least 4 visits. So 4 visits is important. So what is the correct answer? It is 11 to 15 visits. Please remember this MCQ. Just see this bifurcation. The ideal number of antenatal visit is 11 to 15 in total. So how it is bifurcated? See, till 28 weeks. Till 28 weeks, there should be 1 visit every 4 weeks. There should be only 1 visit every 4 weeks till 28 weeks. Next, in 28 to 36 weeks, there should be 1 visit every 2 weeks. There should be 1 visit every 2 weeks. Next, we have greater than 36 weeks. When the mother is more than 36 or equal to 36 weeks, she should have 1 visit every week. She should have 1 visit every week. So this is the ideal number of antenatal visits that is recommended, that is 11 to 15 visits. So you can see, still 28 weeks, it should be 1 visit every 4 weeks. In the first trimester, like in 28 to 36 weeks, it should be 1 visit every 2 weeks. Every 2 weeks. Greater than or equal to 36 weeks, it should be 1 visit every week. 1 visit every week. And what is the WHO's minimum recommendation of antenatal visit? As per 2016 updates, it is 8 visits. It is not 4 visits. Please don't confuse yourself. WHO recommendation is 8 visits. Then when we talk about Government of India's minimum recommendation is 4 visits. So these are the minimum recommendation, but the ideal number of visit is 11 to 15 visits, which is bifurcated as this. Like till 22 weeks, 1 visit per every 4 weeks. 28 to 36 weeks, there should be 1 visit for every 2 weeks. For greater than or equal to 36 weeks, it should be 1 visit every week. So now you can able to find out what is the correct answer, right? So it is 11 to 15 weeks. Now we will go to the next question. A 28 years old woman with a history of delivering a child with a neural tube defect. See, already the patient is a case of neural tube defect. Okay. And is planning to conceive again. What is the most appropriate folic acid supplementation regimen for her? As you all know, in pregnancy, in order to prevent the neural tube defects, we are giving with folic acid supplementation. And we also have an important program in that is your Anemia Mukt Bharat program, where they are giving your, that is specifically for prevention of anemia, megaloblastic anemia. But here in this case, what is the dosage of folic acid specifically to cure the neural tube defect is the MCQ here. Okay, specifically to cure the neural tube defect. So what is the correct answer? Just put in the chat box what is the correct answer. Tell me, if the mother is already a case of a neural tube defect, who has the history of conception of a neural tube defected baby. So what is her recommended folic acid dosage? Now tell me, what is her recommended folic acid dosage? What is her recommended folic acid dosage? Obviously, B is the correct answer. It is 4 mg per day. 4 mg per day is the recommended dose of a person who is already having the history of neural tube defect. That too, what is the sequence of administration? You have to start before 3 months, okay, before 3 months of consumption and continue for 3 months after consumption. Okay, I am drawing a diagram. History of neural tube defect, normal mother, normal pregnancy, right? So here, when to start at history of neural tube defect, you have to start 3 month prior. Okay, you have to start 3 month prior. Okay, if history is there, you have to start 3 month prior. If there is no history, you have to start 1 month prior. 1 month prior. So what is the dosage? What is the dosage? Here, when there is history of neural tube defects, it is 4 mg. When there is no history of neural tube defects, it is 400 mcg. It is 400 mcg. It is 400 mcg. And when to stop? When to stop the dosage? For person with history of neural tube defects, you have to stop after 3 months of consumption. After 3 months. After 3 months after delivering the baby. And if the patient is not a case of neural tube defect, even though, then you have to stop after 3 months only. The folic acid supplementation has to stop after 3 months only. Very good. 1 month before. Right. So here we have this MCQ, like the patient is already having the history of neural tube defect, and what is the recommended dosage of folic acid is the question. So here we are specifically talking about the folic acid dosage to prevent the neural tube defect. So that is 4 mg per day. If the patient is having the history of neural tube defect, that is 4 mg per day. 4 mg per day. 4 mg per day is the correct answer if the patient is having the history of neural tube defect. Right. If the patient is not having any history of neural tube defects, then this is the normal recommended dosage. Okay. Normal recommended dosage, that is 400 mcg per day. 400 mcg per day. So 400 mcg per day, that too when we are starting at 1 month before, starting 1 month before the consumption, and we are continuing for 3 months post consumption also. 3 months post consumption also. This is also very important point to note, like not only when to start, what is the dosage, but also you have to know when to stop the dosage, right? So first, be clear, when the patient is a normal person who we are going to supplement with folic acid in order to prevent. Prevention means what? Prevention means it is prophylactic dose. It is prophylactic dose. It is the prophylactic dose. Whereas this 4 mg with the history of neural tube defects, this is therapeutic dosage. This is therapeutic dose. This is therapeutic dose. Just you have to understand the difference. When it is a normal patient, we are going to give 400 mcg, that is microgram per day, and we are starting it 1 month. Okay, we are starting it at 1 month when, sorry, we are going to start at 1 month when the patient is, we are going to start at 1 month. Okay, sorry. We are going to start at 1 month. Okay, we are going to start at 1 month of your pregnancy, before 1 month of your consumption we are going to start it. And in case of neural tube defect, we are going to start the dosage of 400 mg before 3 months of consumption. And when we are going to stop, when the patient is a case of normal patient, we are going to stop it 3 months. And if the patient is a case of neural tube defect also, we are going to stop after 3 months only. So the stopping is After 3 months only in both the cases. But the starting is, in case of neural tube defect, we are starting 3 months before the consumption. In case of normal mother, we are going to start it 1 month before the consumption. Next we have another options. So 1 mg per day starting at confirmation of the pregnancy. This 1 mg per dosage is given at what case? This is given in case of folic acid deficiency. When the mother is having folic acid deficiency, we are going to give this dosage. You can just note it. This is not additional information. 5 mg per dosage continued throughout pregnancy. This is given in the case when the mother is a case of sickle cell anemia. Sickle cell anemia. Sickle cell anemia. In this case, you are going to give with the 5 mg per day dosage. So just remember, be clear, be clear. Let me again narrate it once again. So let me again write. See, first is dosage, start date and stop, right? This is normal mother and this is history of neural tube defect. So in normal, what is the dosage? In normal, it is 400 mcg. In case of history of neural tube defect, we are going to give 4 mg. When to start the dosage? In normal mother, it should be 1 month before consumption, and here you have to start it 3 months before consumption. 3 months before consumption. When to start? 3 months after the delivery. Here also 3 months after the delivery you are going to continue this. So this dosage is termed as your prophylactic dosage. Prophylactic dosage. Whereas this dosage is termed as your therapeutic dosage. Therapeutic dosage. So what is the correct answer? Obviously the correct answer is 4 mg per day. This 1 mg per day starting at the confirmation of the pregnancy is given when the mother is having folic acid deficiency. Folic acid deficiency, and this dosage of 1 mg per day is given when the mother is having the history of sickle cell anemia. Sickle cell anemia. Right. Next we will go to the next question. Yes. A 97 weeks pregnant woman present with the vaginal bleeding on per vaginal examination, the cervical os is closed. The cervical os is closed and there is a history of passage of product of consumption. The history of passage of product of consumption. The ultrasound shows an empty uterus and the uterine size is less than the period of gestation. What is most likely the diagnosis? See here, they have given about one abortion. All the symptoms, all the signs of one abortion is given. So just find out what is that abortion and answer in the chat box. Now tell me what is the abortion and answer in the chat box. D. Complete abortion. Ishita has came. Ishita is the one who puts lot of messages in the group, right? In the WhatsApp group of Plan MSc. Very good. Very good. Akshara. Yes, it is the case of complete abortion. Since all the symptoms, let us narrate the symptoms. Okay. So first what they are telling. Present with vaginal bleeding. Okay, 7 weeks pregnant women present with vaginal bleeding. On per vaginal examination, the cervical os is closed. Os closed, and there is a history of passage of products of consumption. So patient has the history of passage of product of consumption, which means the abortion is completed. She has already passed the product of consumption. Next, ultrasound shows empty uterus, which means it is completed. The abortion process is completed. Since the mother has let out all the product of consumption, the uterus is empty. Okay, the uterus is empty on USG. The uterus is empty on USG. Next, and the uterine size is less than the period of gestation. Obviously, the height of the uterus is less than the period of gestation age. So the most probable diagnosis or the actual diagnosis of this scenario is complete abortion. The actual scenario of this condition is complete abortion. Right. So next we will discuss all the types of abortion so that you will have a better understanding of this abortion cases. Right. First is your, just we will have a small table. Threatened abortion. So what is meant by threatened abortion? Tell me what is meant by threatened abortion. Threatened abortion is the process where the abortion process begins. Okay. Abortion process begins, but it can be reversible. It can be reversible. Threatened abortion is abortion process begins, but it is reversible. The abortion can be reversible. Okay, that is threatened abortion. So what is the sign the patient will have? The patient will have spotting. The patient will have spotting. Pain may be present or not present. The patient will have spotting, but pain may be present or not present. So next we have the height of the uterus. So the height of the uterus, the height of the uterus will be equal to the period of gestation. The height of the uterus will be equal to the period of gestation. Any people is answering? Yes. The height of the uterus will be equal to the period of gestation. The next component which we are going to see is the os. The internal os of your cervix, it will be closed in case of your threatened abortion. It will be closed. The next column which we are going to see is the USG. In USG, you can see the live fetus. In USG, you can see the live fetus. In USG, you can see the live fetus. So now we have learnt about threatened abortion. What is threatened abortion? Threatened abortion is the case where the abortion process is started, but it is reversible. When we do appropriate management in case of cervical incompetency, when we are going to put the patient on the circle arch, it is reversible. Somehow we can able to manage and save the fetus. That is termed as threatened abortion. Okay. So the abortion process begins, but it is reversible. Next we have the signs of threatened abortion. The spotting is present. The minimal bleeding and spotting is present, but the pain may be present or it may be not present. The pain may be present or not present. And height of the uterus. The height of the uterus will be equal to the period of gestation because there is no product of conception is coming out. There is minimal spotting is there. The product of conception is not out. Just the abortion process is started. Next we have the internal os. Since the product of conception it is not passed. So the internal os will be closed only because the fetus, the process is started. It is not completely aborted. So the internal os is internal os is closed. Next on the USG, you can find the live fetus. So this is the concept behind your threatened abortion. Next we are going to see about your inevitable abortion. I will use different colors so that it makes some sense. So next is your inevitable abortion. Just remember, inevitable abortion is exactly different from your threatened abortion. In inevitable abortion, the process of the abortion starts and it reaches the stage. Okay, the process of abortion starts starts and it reaches the stage where it is irreversible. Here you have to note, this is the important term which you have to notice. In inevitable abortion, the abortion process has been started, but it is irreversible. We cannot save the fetus. There is no history of passage of product of conception. Here there will be no history of passage of product of conception. There will be no history of passage of any product of conception. Okay, and again there will be the height of the uterus will be equal to the period of gestation. The height of the uterus will be equal to your period of gestation, but the classical difference is the internal os will be opened in this case. And what you can find is in the USG is your dead fetus. Just remember, threatened abortion we have seen, it is where the abortion process begins and it is reversible. And what about the signs? We have been seeing that the spotting is present and pain may be present or not present, and height of the uterus will be equal to the period of gestation, and the internal os is closed, and the USG we can see live fetus. But in case of inevitable abortion, the process of abortion starts and it reaches the state of irreversibility. The process cannot be stopped. The abortion starts to begin, and it reached the stage where it is irreversible. Next you have to know, there will be no history, the signs you have to note, there will be no history of passage of the product of conception. The product of conception is retained inside the uterus, and the height of the uterus will be equal to the period of gestation because the product of conception is inside the uterus. Next we have the internal os is opened because the abortion process has been started here, right? Next, in the USG you can find the dead fetus. Right? In the USG you can find the dead fetus. Next we are going to see incomplete abortion. So what is incomplete abortion? Can you able to tell me where the process of abortion starts and the product of conception started to come out? Okay. Now we are going to see about incomplete abortion. In incomplete abortion, what has happened? The process of abortion starts. The process of abortion starts. The product of conception starts coming out. The product of conception starts coming out. The product of conception starts coming out. And what is the other thing happening? But the process is incomplete. The complete product of conception is not out here. The complete product of conception is not out here. That is the classical finding. So, since the product of conception is out, the patient will be having severe bleeding. Severe bleeding and pain will be there. Severe bleeding and pain will be there. Severe bleeding and pain will be there. So now tell me, what will be the height of the uterus according to the period of gestation? Obviously, the height of the uterus will be less than the period of gestation. The height of the uterus will be less than the period of gestation. The height of the uterus will be less than the period of gestation. Now tell me, what about the internal os? Obviously, the internal os will be opened because the period of the product of conception starts coming out, which means it is incomplete. Some of the product is retained inside and some of the partial product is started coming outside. So obviously the os will be opened. So what will be the USG findings you can see. Incomplete part of the uterus 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 you can see. Right? Incomplete parts of the uterus you can see in this incomplete abortion. Next we are going to see about complete abortion. Next we are going to see about what abortion? It is complete abortion. So tell me, what is complete abortion? The definition of complete abortion. Or you people are on the track or you're not on the track? Tell me, everyone is on the track. Just put me a thumbs up or message that everyone is following the class. Yes. Just tell me, what is complete abortion? The entire product of conception is out. In complete abortion, entire product of conception is out. The entire product of conception is out, and the patient will be having the product of conception out plus bleeding, and this will be like a history. The patient will tell, already I passed everything, like there was lot of bleeding from my uterus. The patient will tell there is a history. Okay, I already had a lot of bleeding, ma'am. Like that they will be complaining. They will be complaining to us. So this is what is the process. The patient will be telling that there is lot of bleeding. The product of conception is completely came out, and she will tell that is a history, and she will tell at one point the bleeding is stopped. At one point the bleeding is stopped. Like that she will be complaining. Like that she will be complaining. So what about the height of the uterus? Obviously, since the fetal product has been came out, the height of the uterus is going to be less than your period of gestation. And what about the uterus here? What about the os here? Since the process is completed, the os will be closed. The os will be closed. Since the mother has expelled all the fetal particles, all the fetal period of like product of conception out of the uterus. So since the process is completely complete, the abortion process is completely complete, what will happen? The internal os will be closed. The internal os will be closed here. So what will be the USG findings? There will be empty uterus. Okay, there will be what? Empty uterus. There will be empty uterus. There will be empty uterus. So what's the another kind of abortion you have to study is missed abortion. The last abortion which we are going to see is missed abortion. In missed abortion, what is happening? In missed abortion, here where the abortion process has been started and the mother is not aware that she got aborted, right? Fetus is the fetus is dead inside. Okay, the fetus is already dead inside. The fetus is dead inside. Dead inside. And the mother is not aware of it. Mother is unaware. Mother is unaware. Okay, that is called as missed abortion. Missed abortion is process is started, the fetus is dead inside, and the mother is not aware that the fetus is dead and she got aborted. Right. So here what will be the signs and symptoms? There will be brownish discharge. Brownish discharge. Brownish discharge will be there. There will be brownish discharge. Now tell me, what will be the height of the uterus in respect to the period of gestation? It will be less than the period of gestation. And what about the os? Obviously no product has came out, it is closed. And what is the USG findings? It will be macerated uterus, macerated fetus. Macerated fetus. There will be macerated fetus. So this is all about abortion. Once you remember these concepts, it will be very easy for attempting any kind of abortion questions. And one more thing you have to remember in this is, whenever you see a patient with abortion, what is the first line management which except threatened abortion, what is the first line management the nurse is expected to do is to start the abortion process completely, to start the abortion process properly and to complete it earlier and make the mother to rest. In case of threatened abortion, what is the management? In case of threatened abortion, the first management is 48 hours of rest, and the mother is given with a diazepam, and the mother is advised not to do any heavy work after that particular during the period of the pregnancy. So that is the advice. In case of inevitable abortion, in this cases the management starts with the picking up the process of abortion and completing it further. Here we will do suction evacuation followed by suction evacuation. If it is not completely evacuated, then we will be using this curettage. Blunt curettage will be done in this pregnancy. Blunt curettage will be done, and we will be evacuating the fetus completely. Then we will be giving the oxytocin dosage and we will be evacuating. This is the process for all other abortions. Like, we have to evacuate the uterus and we have to complete the abortion process. That is the process between us, right? So next we will start, we will have a quick recap. First is threatened abortion. Threatened abortion is the process where the abortion process is started, but it is reversible, which means I can able to make some management and I can able to reverse the baby, right? So next is, what is the signs and symptoms of threatened abortion? Spotting and pain may be present or not present. Next is height of the uterus. Height of the uterus will be equal to the period of gestation because the abortion process is started, but it is not. It is reversible always. Reversible also. There is no passage of any period of product of conception. Next, the internal os is always closed. Next is in USG, there will be live fetus where you can do the management and you can able to save the fetus. Next we have inevitable abortion. In inevitable abortion, the abortion process is started. It is just opposite to the threatened abortion, where the abortion process will be reaching the state of irreversibility. Irreversibility means you cannot save the fetus because the mother will start to pass. Okay, the mother will start the process of abortion so quickly. And in the signs and symptoms, you can see there will be no history of passage of the product of conception. In inevitable abortion, there will be no history of passage of product of conception, but the mother has reached the stage where it is irreversible. Okay, that is inevitable. Like, an unfortunate event can happen. That is the meaning of inevitable. You have to remember in that way, where even though the product of conception is not coming out, in this inevitable abortion, it is irreversible. Alright, and the height of the uterus will be equal to the period of gestation because there is no product of conception is coming out, obviously, but the exception you have to notice, the internal os will be opened. The internal os will be opened in case of your inevitable abortion. So what is the status of the USG? In USG you can see the fetus is dead and there is no cardiac activity, right? Next is your incomplete abortion. In incomplete abortion, the process of abortion starts and the product of conception starts coming out for the mother, and some product will be retained inside the uterus itself. Some products of conception will be retained inside the uterus itself. That is why it is termed as incomplete abortion. That is why it is termed as incomplete abortion. Here you have to note, so the mother will be telling, mother will be start to tell, like, the product of conception started coming out. The mother will be having bleeding accompanied with pain. Bleeding accompanied with the pain. So what about the height of the uterus? Since half of the fetal particles are started coming out, the height of the uterus will reduce in respective to the period of gestation. Next, what about the os? Obviously the internal os will be open because the mother started letting out the product of conceptions. So in the USG, what is the finding you will be seeing in case of incomplete abortion? It is incomplete parts of the fetus will be seen in the USG. Next we have complete abortion. Just remember, entire product of conception is out in case of your complete abortion. That's why it is termed as complete abortion. And the product of conception is completely out and the patient will be having bleeding. Then she will tell there was a history of bleeding. Now I don't have any bleeding. Like that they will complain. Next is, what about the height of the uterus? Obviously the height of the uterus will be less than the period of gestation. And since the product has been completely out in case of complete abortion, so the os will be closed only. The os will be closed only. Next, in USG, what is the findings you will see? It will be the empty uterus. Next, we have at last the missed abortion, where the fetus is dead inside the uterus. The fetus is dead inside the uterus and mother is unaware that the fetus is dead. So what is the things you can see? The signs and symptoms will be brownish discharge. And what about the height of the uterus in respective to the period of gestation? Obviously, it is going to be less than the period of gestation. So the os will be completely closed because the abortion process is not at all started, but the fetus is dead inside the uterus. Right. Next, what is the USG findings you will see? It is the macerated fetus you can see in the USG findings. Now coming back to the question, a 7 weeks pregnant woman present with a vaginal bleeding on per abdominal examination. Per vaginal examination, the cervical os is closed and there is a history of passage of product of consumption. History of passage of product of consumption, which means in this complete abortion, the mother will tell, I already had a very good bleeding. I already have seen some parts of the fetus. Like that she will be telling. Right. And ultrasound shows empty uterus, which means the complete product of consumption is evacuated and the uterine size is less than the period of gestation. Then the condition is your complete abortion is your correct answer. Right. Next, we will go to the next question. So a 20 years old woman from a rural village present with the vaginal bleeding, abdominal cramp. Present with vaginal bleeding and lower abdominal cramp. She had amenorrhea for 7 weeks and was diagnosed with incomplete abortion. Incomplete abortion means what? Half of the product of the conception is out and half of the product is retained inside the uterus. Right, since they have given the definition itself. The nearest health facility has no electricity supply. Testing your skills. There is no electricity supply. And what is the most appropriate method of uterine evacuation in this patient is advised. So just remember, they are telling there is no electricity. The patient is a case of incomplete abortion where some amount of products of the fetus is retained inside the uterus. So what is the finding? What is the next level management we are going to do? Suction evacuation using Carmen cannula and suction machine. This required electricity, so we are rejecting this option. Dilatation and curettage under general anesthesia. This is going to further worsen the condition. This is going to happen. This is not the first line management. In the next step, we are going to do dilatation and curettage, but it is not the first line management. Just tell me what is the answer. Manual vacuum aspiration using 60 ml syringe. Yes, notable. Menstrual regulation using 50 ml syringe with no vac. No, this is also the wrong answer. The correct answer is manual vacuum aspiration using 60 ml syringe is the correct answer. Yes, Ashish, Akshara, Ashish again, Ishita, all have answered the correct answer. So since there is no electricity supply, so what happened? We have to go for the manual aspiration. Carmen's cannula with the use of suction catheter needs electricity. So in this situation, the best method for evacuating is your manual vacuum aspiration using the 60 ml syringe. And as I said you, the important management when the patient is coming with a case of abortion is to complete the abortion process as soon as possible and to maintain the well-being of the patient. Right. And I would like to show you the few important components of your manual vacuum aspiration. This is the manual vacuum aspiration syringe. Okay. Manual vacuum aspiration MVA syringe. Okay. This is your MVA syringe. Okay. Next. So in areas without electricity, suction machines cannot be used. In this case, we are using this manual vacuum aspiration syringe. So MVA syringe is used with 2 pinch valves. Remember, MVA syringe is used with 2 pinch valves and it generates 660 mm Hg of pressure. The Carmen cannula exerts only 600 mm of Hg, but it generates 660 mm of Hg of pressure. Maybe they might be asking a question on specific pressure, so you have to note this also. And the syringe capacity is 60 ml And gestational age where it can be used, it can be used in 7 weeks of gestation. MVA is suitable and safe. And Carmen cannula can still be used but with MVA setup. Okay, but it requires electricity. Menstrual regulation syringe is absolute and limited, less than 6 weeks only. Lack of effective vacuum. Okay, so menstrual regulations will be advised when the patient is less than or equal to 6 weeks. When the patient is at the 7 weeks of gestation, when the electricity is not there, the manual vacuum aspiration is the most important technique you can follow. Right? Next, we will go to the next question. So, which of the following best describe the pathogenesis and genetic pattern of complete hydatiform mole? Like, before coming into this question, we will have the detailed overview of what is complete or vesicular mole, what is the morphology and everything. So, first is the pathogenesis. So, a complete vesicular mole, and villi will be there. Trophoblastic, in both the cases, trophoblastic proliferation will be there. Okay, the fetal tissue, no fetal tissue will be there because it is complete mole. Some fetal tissues can be found in the histopathological findings. Right? So now coming back to the question. Okay, coming back to the question. Which of the following is best describe the pathogenesis and genetic pattern of the complete hydatiform mole? Now tell me, what is the pathogenesis of the complete hydatiform mole? Obviously, what is the correct answer? Fertilization of the one empty ovum. Fertilization of the one empty ovum by one sperm resulting in diploidy 46XX. So here also we have 46XY, which is not actually the finding of your complete hydatiform mole. And fertilized of an empty ovum by 2 sperms. No. In this also it is not empty ovum. It is the ovum which is fertilized by 2 sperms. Is 69XXY is triploidy is seen in your partial mole, not in your complete mole. Fertilization of the normal ovum. No. Normal ovum nahi. No. It is an empty ovum. Next, fertilization of the ovum with a maternal chromosome. No, the maternal chromosome is not at all there. Only the paternal chromosome is there. Preserved and diploid pattern is 46XX. No, this is wrong. So the correct answer is fertilization of the empty ovum by one sperm. And what is the chromosomal feature? It is a diploidy 46XX. It is a diploidy 46XX. Next, we will go to the next question. A 26 years old woman present with vaginal bleeding, okay, a 26 years old woman present with vaginal bleeding and a uterine size larger than expected. The uterus size is larger than expected, okay, for the gestational age. No fetal heart sounds is heard and detected. Her serum beta HCG is markedly elevated. What is the term markedly elevated means? Markedly elevated means it is more elevated. Markedly elevated means it is more elevated. Okay, that is termed as markedly elevated. Next, which of the following is most likely to the diagnosis? Since the patient is having the vaginal bleeding, severe vaginal bleeding, and you can also see the uterine size is larger than the period of gestation, this happens in case of the complete mole. This happens in case of the complete mole. Okay, complete vesicular mole. And you can also see the beta HCG is markedly higher. The beta HCG is markedly higher, which means the beta HCG level is more. So which in turn obviously tells that this condition is your complete vesicular mole. Complete vesicular mole is the correct answer. So a pregnant woman, yes. The next question. So before going to this question, let's discuss about the important condition. These are antepartum hemorrhages. Antepartum hemorrhages. right? First is placenta previa. What is placenta previa? Placenta previa is the condition where there will be the placenta is misplaced. Okay, placenta is misplaced, and in case of placenta previa, what is the important classical findings you have to see? There will be no pain, bleeding will be bright red, and recurrent bleeding will be there. The fetal impact is usually normal, and key feature, causeless warning hemorrhage is there. Causeless and warning hemorrhage is seen in case of placenta previa. Next we have abruptio placenta. Just remember the classical findings. In case of abruptio placenta, there will be pain. There will be pain. And there will be dark red concealed or revealed kind of bleeding will be there. Dark red concealed or revealed kind of bleeding will be there. And fetal distress is most possible in case of abruptio placenta. Then it is caused because of your PIH and trauma and premature rupture of membranes, and it can be not recurrent also. So because of the trauma, if they ask like the antepartum hemorrhage which is happening because of trauma, then it will be your abruptio placenta. Next we have vasa previa. There will be no pain again like your placenta previa, and there will be also bright red bleeding will be there, but there will be minimal bleeding, and marked fetal distress can also be seen in case of your vasa previa. And this can occur after the artificial rupture of membrane and your fetal bleed and velamentous cord insertion. In this condition you can see vasa previa. Next is uterine rupture. Obviously uterine rupture is a major condition which causes severe pain and bright red bleeding will be there, fetal distress, and at last your fetal heart sounds will be absent, and history of LSES and obstructed labor or misoprostol use can be the risk factor for the uterine rupture. Next is, so what is the classical findings which is seen in the abdominal examination in case of your antepartum hemorrhage? This is very important table you have to note. The first is, in placenta previa, the uterus tone will be relaxed and soft. The uterus tone will be relaxed and soft. In case of abruptio placenta, it will be tense and tender because of any trauma. So abruptio placenta may be caused, and which causes tense and tender. In uterine rupture, tender may become soft post rupture. Initially it will be tender, post complete rupture it becomes soft. So what about the uterine tenderness absent here? Present in abruptio placenta, severe and generalized uterine tenderness will be there in case of your uterine rupture. So uterine contour in placenta previa, it is well defined, lost and not defined in case of your ruptured uterus. So what about the fundal height in placenta previa? It will be equal to the period of gestation. In case of your abruptio placenta, it will be greater than the period of gestation because of the concealed bead. That's why there was a there will be dark color bleeding will be there in case of your abruptio placenta, and variable findings of bleeding will be there in your uterine rupture. What about the fetal parts in placenta previa? Not easily felt. Again, in abruptio placenta, it is not easily felt. Superficially palpable because of the ruptured uterine cavity. Fetal heart sounds normal in case of placenta previa. Fetal distress is seen. Absent or severe fetal distress, marked fetal distress will be seen in case of uterine rupture. Next, abdominal tenderness absent in case of your placenta previa, present in case of your abruptio placenta, and it is also present in case of your what? Uterine rupture. Next we have the old classification of placenta previa, which is also very important to know. Type 1 is lateral, placenta edge within 2 centimeter of the internal os. Okay, the placenta will be just above placed just above 2 centimeter away from the internal os. That is called as, in the new classification, it is called as low lying placenta. 2 centimeter away from the internal os. Next is type 2 or marginal placenta. Okay, placenta edge reaches the margin of the internal os. So type 2 marginal placenta, like marginally it will touch the margins of the internal os. That is what is termed as marginal placenta. That is old classification, type 2. The new classification is placenta previa, where what happened? Now is it audible? Now it is audible? Yes. See, now it is audible? Yes. So, in type 2 placenta, marginal placenta, okay, where the placenta edge reaches the margin of the internal os, according to the new classification, it is termed as placenta previa. Placenta previa. Next is type 3, which is incomplete. Placenta partially covers. First in type 2, what happened? It has just touched the margin. Here in type 3, in incomplete, it has slightly partially closed the internal os. It is placed partially closing the internal os. So that is called as what? Type 3, that is your, again according to the new classification, it is termed as placenta previa only. Next is type 4, that is complete placenta previa, where the placenta completely covers the internal os. That is also according to the new classification is termed as placenta previa. Type 2, type 3, type 4 in combination, 3 of them is termed as placenta previa according to the new classification. Whereas your type 1, where it is 2 centimeter away from the internal os, is termed as your low-lying placenta. Now coming back to the question, a pregnant woman at 34 weeks of gestation present with painless recurrent bright red vaginal bleeding and no history of trauma. On examination, the uterus is soft, non-tender and fetal heart sounds are normal. What is most likely the diagnosis? Just tell me, children, what is most likely the diagnosis? Yes, C-section is done in type 4 placenta previa. Just now tell me what is the answer for this question. The patient is having 34 weeks of gestation, painless, recurrent, bright red vaginal bleeding and no history of trauma. Since no history of trauma, we are concluding it is not abruptio placenta. On examination, the uterus is soft, non-tender, fetal heart sounds are heard. Obviously, what is the diagnosis? The diagnosis is placenta previa. The diagnosis is placenta previa. Very good. Akshada and Jihlik Brahman. Very good, very good. This is the correct answer. Yes. Now we will go to the next question. So a 28 years old pregnant woman present for her first antenatal checkup. Her hemoglobin level is found to be 8.5 grams per dl. 8.5 grams per dl. According to WHO classification, this would be categorized as what? So just note, it is 8.5 gram per dl. According to WHO classification of anemia, you have to tell me this comes under what kind of anemia? This comes under which classification of anemia? This condition comes under which classification of anemia? 13B. Very good. So Jihlik. Sorry for mispronouncing your name. Yes, the correct answer is moderate anemia. To have a better picture, just look into this content. According to WHO national guidelines, mild anemia is classified when the HB is 10 to 10.9 gram per dl. Moderate anemia is 7.7 to 9.9, where 8.5 is falling under this category. So the answer for our question is moderate anemia. Severe anemia is where the HB is less than 7. Very severe anemia as per ICMR. This is as per ICMR. Very severe anemia is HB less than 4 gram per dl. Less than 4 gram per dl. In this case, since our question is stating 8.5 gram, it is moderate anemia as per the classification. Now tell me, which of the following teratogenic drug is correctly matched with the fetal anomaly? What is the correct answer? What is the correct answer? Tell me. Which of the following teratogenic drug is correctly matched with the following conditions? Tell me. Thalidomide, what is the condition which is accompanied with thalidomide? The most important question. Thalidomide is accompanied with phocomelia. So the option is incorrect. Warfarin is Dissler syndrome. This is correct. Misoprostol causes what syndrome? Any answers? What is Mobius syndrome? Misoprostol causes Mobius syndrome. Mobius syndrome, which is the 6th and 7th cranial nerve palsy. 6th and 7th cranial nerve palsy. Next is indomethacin. What indomethacin causes? Indomethacin causes what? Tell me fast. Indomethacin causes premature closure of tell me what indomethacin causes? Premature closure of your ductus arteriosus. So the correct answer is warfarin, which causes Dissler syndrome. Warfarin causes Dissler syndrome. What is meant by Dissler syndrome? Dissler syndrome causes chondroplasia, stripped epiphysis, nasal hypoplasia and CNS abnormalities, which is caused by the warfarin. Okay. And now tell me, thalidomide comes under which category of drug? According to pregnancy safe drug category, thalidomide comes under category X. Category X, where the risk is more than the benefit. So, what is the answer here? Category X. Thalidomide is coming under your category X drugs, and the properly arranged teratogenic drug according to the fetal anomaly is warfarin, which causes Dissler syndrome. Next, which of the following antihypertensive drug is contraindicated in the treatment of chronic hypertension of the pregnancy? Now tell me what is the correct answer. Shirik is very active, very good, you are telling the correct answer. Now tell me what is the drug? Which of the following antihypertensive drug is contraindicated in the treatment of chronic hypertension? Yes, I am waiting for the answers. Please answer fast. Answer me. I am waiting for the answer, my dear children. Which of the following drug is not administered, is contraindicated in case of chronic hypertension? Obviously, the answer is hydralazine. Hydralazine is used in the management of acute preeclampsia. Okay, it is used in the management of severe acute preeclampsia. But it is not used in case of chronic. It is contraindicated in case of chronics. Whereas your labetalol, methyl-dopa and nifedipine can be used in chronic hypertension. Right? So this is all about the OBG MCQs. I think the community MCQs I will cover in the next session. Okay, the community MCQs I will cover in the next session, dear children, because it's already time. Let me cover the community MCQs in the next session. Okay. So the last question is all about the contraindicated drug in case of chronic hypertension is your hydralazine, whereas your methyl-dopa, nifedipine and your labetalol can be administered in case of chronic hypertension. But hydralazine is a drug which is contraindicated in the chronic hypertension in pregnancy. Yes, methyl-dopa is the second priority. Okay, fine. Just I am concluding the session. Just tell me, is the session was useful to you people? It was productive. Okay. With this, I am concluding this session. Communities MCQs I will be discussing in the next session for you all. And thank you so much for watching. If you want to see all these concise tables and concise forms which I am curated, which you have seen in the classes, You can follow my page, that is Nursing with Priya Balan on Instagram, and you can also share your scientific queries. When you have any specific scientific queries, you can also share with me, so that I will be interacting with you and solving your scientific queries also. And thank you so much for watching. Next session will be, obviously it will be announced soon, because your response are very good and I'm very happy to see your responses also. So next session will be held very soon, and I just want you to put the feedback of the session. And thank you so much for watching. Here we conclude the session. Thank you. I will call. So